Thank you. The purpose of the talk today is to look at some of the data with regard to the role of EMS in hyperacute stroke treatment. And before we get started, I just want to give you the source of the data. And this is the guidelines that are put out on a regular basis by the American Heart Association, American Stroke Association. And this particular paper is entitled Early Management of Adults with Ischemic Stroke. And it's written by a number of physicians, but it starts out with Adams. And it's in the journal Stroke 2007, volume 38, pages 1655 to 1711. And this would be the recommendations of the American Heart Association, which they come out and they review them. And the last review was in 2011 with no significant changes in this part of the guidelines. So emergency medical services, well, what kind of a role do they have with regard to hyperacute stroke treatment presently? What they found by looking at a number of studies, that 29 to 65% of people with stroke symptoms rely on EMS as the source of their initial medical care. And then somewhere between 19 and 60% of stroke patients arrive in the ER within 3 hours of symptom onset. Now that's quite variable, and part of the reason for that is that this is looking at all comers. So this could be more rural areas or more urban areas. And I think that could be responsible for that wide variation in the number of patients that would come in by ambulance that arrive within the 3-hour time window. And then of those who do get in within the 3-hour time window, the majority, this being about 52%, arrive by EMS. With regard to EMS activation, the majority of it is by a family member, caregiver, co-worker, or bystander. So it's a person in the community that has recognized the stroke symptoms. The bystander is often very helpful. My big example for that is we have a flower shop in Fort Smith, and the owner had been to a stroke talk, and she has identified 2 stroke victims on the sidewalk outside of her flower shop already. So she's very productive. But I think that, you know, we want to make sure that we extend this to our entire community, you know, even the kids in school and that sort of thing. Everybody can learn the signs and symptoms of stroke. 911 is more likely to be called if the patient has a high stroke severity. And this is, again, the lady lying out on the sidewalk, can't move. Intracerebral hemorrhage, horrific headache, I'm vomiting, I look toxic, you know, they look really sick. Advanced age, and I think part of that is due to the severity of stroke with advanced age, but also caregivers close by, that sort of thing. And then a sense of urgency on either the part of the patient or the caregiver, and that sense of urgency often comes from recognition of the significance of the symptoms. That if you think that this is something that will go away with a nap, then you'll take a nap. If you know it's a stroke and that there's a treatment for it, then you're going to have a greater sense of urgency and come in. So education is huge. With regard to EMS transport, hospital arrival time is shorter if a 911 is called, as opposed to the caregiver or whoever is calling in the stroke calls their local medical doctor or a hospital. And the reason for that, I'll just give you my own office, that if my patient were to call my office, they would get my receptionist, who by the grace of God has to recall that those are stroke symptoms and then tell Susan. And then she has to be able to reach Susan, and then Susan's got to tell me. So there we've got several minutes going by before we figure out what's going on. Probably Susan would tell them to call 911, and there still are minutes that are lost. If it's the hospital, they're going to get the operator. The operator's going to get in touch with the ER. The ER's got to figure it out and get a nurse, and then the nurse will say, come into the ER. So we've wasted way too much time with that. So it is very important that we call 911, and that's purely because 911 is capable of addressing this issue rapidly. Shorter time intervals from symptom onset to hospital arrival is seen also with EMS activation, and shorter time to physician evaluation, getting a CT and a neurologic exam. And the reason for that is, especially in our state, is that we can notify the ER that we have an incoming stroke patient. So the ER physician and the nurse and people can be ready to receive that patient and give the appropriate life-saving care. Emergency medical services, the first aspect of it is dispatch. This is the first encounter with the patient. The role of dispatch is to triage and dispatch the appropriate provider for the patient that they're receiving the phone call from. Dispatchers currently, this is a study that was done, currently dispatchers correctly identify 52% of patients who have had a stroke based on that initial phone evaluation. So what I would like to do, 52 is wonderful, it's more than half, but for our purposes we need to look at the problem, and that is that 48% of the time they got it wrong. And so I see this as an excellent opportunity for us to go out in our communities and really try to include dispatch in our educational programs to make sure that they know stroke. And we actually had some discussion on this in our breakout, our last breakout. If we want to talk about that more, we can at the end. And there needs to be a priority that dispatch places on a hyperacute stroke that is similar to the acute MI or the trauma patient. Dispatch knows what to do when they get a trauma or they get an acute MI calling in. It's an immediate call to them. I got a potential MI, I got an acute trauma. That means lights and siren both to the house and into the ER. If it's a patient, she's going to call and say, Grandma fell again. Then EMS, at least in our area, they do go and they pick people up and put them back in their wheelchairs if they're too heavy for the caregiver to pick up. That isn't a lights and siren out to the house. But if she had asked, or he had asked the appropriate question, it wouldn't be a fall from the wheelchair, it would be an acute stroke. That would be a lights and siren out to the house, that sort of thing. So dispatch really can help us prioritize those calls. As far as EMS itself is concerned, the initial evaluation recommendations are always your ABCs first: airway, breathing, and circulation, cardiac monitoring, establish IV access, finger stick glucose, getting some good vital signs, and if the O2 sat is less than 92%, the recommendation is just put them on a little bit of oxygen by nasal cannula or face mask, whatever's the most appropriate, and keep the patient MPO because you don't know what's going to happen when they get to the ER. Again, that initial evaluation, if you have a hyperacute stroke patient, you want to alert the ED of incoming stroke patient. Rapid transport to the closest appropriate facility capable of treating an acute stroke. This is a recommendation of the American Heart Association. So if you have a number of hospitals en route and they're within, a reasonable length of time, and hospital A has no capacity for treating hyperacute stroke, and you have a hyperacute stroke patient, but a couple of miles down the road, hospital B does have that service, the recommendations of the American Heart Association is you take them to hospital B, because they can get appropriate stroke care there. It is not, to my knowledge, part of our legislation in our state that still we have the nearest hospital, but we could also let the patients know the capacity of the various hospitals en route to the stroke hospital. You don't want to give dextrose-containing solutions to these patients unless hypoglycemia is present. Then you want to treat the hypoglycemia. And also, you do not want to reduce the blood pressure unless the systolic exceeds 220 or the diastolic exceeds 120 until you get into the ER, and then the physician can make a decision of what will be treated at that point in time, whether they truly are a hyperacute stroke patient or not. Also, to limit excessive IV fluid hydration on the way to the emergency room. As far as the symptoms of stroke, there's a number of different protocols out there for identification of stroke in the field. The LA Pre-Hospital Stroke Screen is the one that the American Heart Association talks about the most. They also spoke about the Cincinnati Stroke Scale, saying that they were the two scales that they cited that had sensitivity, specificity data that made them ideal for community use. And this involves, and no matter what scale you use, you should have these points addressed. Time of symptom onset, which we all know is the last know well time. And then brief history of recent events, stroke, MI, trauma, surgery, bleeding, things that would be involved in consideration for TPA. If they have any comorbid diseases, in particular those that would need to be addressed, in hyperacute stroke treatment, like diabetes and hypertension. And medications, either bring a bag of them or an accurate list, but you need to bring the medicines along, in particular anticoagulants, antihypertensives, and insulin, if those are being used. You really, if you can get those questions addressed, but you want to address these things rapidly. If it looks like you're not going to get the answers that you need, then you just want to get the patient to the ER. It is most important that the family travel to the hospital immediately. Now, this is a problem that I face routinely at our hospital, that it seems that because this is a tragedy, stroke is a family tragedy, that they want to pick up every single family member on the way into the ER. And that is not in the patient's best interest. You want someone who can give consent and a history to be going to the ER, or get a cell phone. If you know dang well that they are going to pick up the entire family, get a cell phone and tell them they're going to have to answer it, that a doctor is going to be calling them, because we're going to have to verify the last known well time. EMS will get an accurate last known well time, but the physician has got to verify that, because oftentimes there's one golden question that the doctor asks, and that changes the last known well time. And so we have to verify that, because we're responsible for our actions as physicians. So we have to be able to talk to somebody. It's so difficult to go off hearsay. So phone numbers of witnesses, and then again, the flower shop lady, get her phone number. If she's the one that witnessed it, get her phone number, even if she's not coming in, so that you can call her and tell her to stay by her phone, that this is most important. If she cared enough to call EMS, she'll care enough to stick by her phone, or his. The management, the most important thing of EMS management prior to arrival in the ER is transport the patient as soon as possible. You establish cardiac monitoring and IV access en route. So get them in the van and get moving as fast as you can. The quicker they get to the ER, the quicker we get the studies, and the quicker the telemedicine begins, and the quicker we can give them that bolus of TPA, which is the most important thing on that whole process, is getting that bolus in ASAP, but we want to do it safely. And if you're going to start a fluid, saline, don't start dextrose. And TKO or 40 cc's an hour, whatever you want to do, would be fine. There was a task force designated by the National Institutes of Health called Improving the Chain of Recovery for Acute Stroke in Your Community. And they are a distinct task force from the American Heart Association, and they also have recommended identifying a hospital capable of providing acute stroke care and creating a transport system to these centers based on patient location. This requires advanced planning and frequent updating, and it should incorporate EMS in particular, but community leaders, the hospitals that are involved, both those that are capable of treating and those that are not capable of treating, need to be involved, as well as physicians that are involved in hyperacute stroke treatment, and make sure that EMS has clear guidance for who they are to transport these patients to. And then the frequent updates is the best way to increase the level of care in your community, is to say that expert care that can take care of these patients are the ones we're going to send our patients to. I can tell you brand X is going to get that certification ASAP, because they're not going to let brand Y take those patients away from them. So now we have 2 hospitals in our primary stroke centers. I think that's wonderful. I think competition is great. But if you say that you can bring them to a hospital that's not capable of treating them as much as you would bring them to a hospital that is capable of treating them, that offers them no incentive to improve themselves. But again, in the state of Arkansas, we don't have any mandate for that. These are just recommendations from national organizations. Aeromedical transport is vital in the chain of transport or chain of treatment of the patient. It can extend the range of thrombolytic therapy for patients in rural areas. It can facilitate an early diagnosis and treatment for hemorrhagic patients, get them into the hospital quicker. And it's a mechanism for transports of patients that are at potential for getting thrombolytic therapy. And it has been demonstrated in studies that it is cost effective. Some of these patients, if you have elevated NIH stroke scales, which you're looking at incorporated in that, is if they didn't get the thrombolytic therapy, what would be the cost of lost productivity and rehab nursing home type placement, that sort of thing. And also they can facilitate, as we all know, the timely transfer of patients who do receive thrombolytic therapy at a rural hospital through telemedicine and then need to be transported to a hospital that has intensive care services for the TPA patient. So the recommendations of the American Heart Association currently, as far as dispatch, is community awareness programs, community education public education to encourage the use of 911 when signs and symptoms of stroke are seen, so they need to know what the signs and symptoms are. EMS dispatch needs to be educated to recognize stroke symptoms based on that phone interview, and then to appropriately notify the providers. EMS will go out and pick up the patient about the severity of the patient, that this is a level 1, this is kind of like a trauma, this is a same level as an MI patient. EMS transport, rapid identification of stroke symptoms using whatever scale that they can be trained in and that they are proficient in. Eliminate stroke mimics. I didn't talk about it all today because that's what we talked about last year, but we could address those if there's any questions. Stabilization of the patients, that's the ABCs that you do. Make sure they've got good O2 sats. Rapid transport to the closest appropriate emergency department. And notification in the emergency department of an incoming hyperacute stroke patient. What we use in our areas, we have incoming code stroke. And so that way we're prepared when the patient arrives to get the workup done immediately and notify the appropriate professionals for treatment. As far as community providers, this would be the physicians in our community as well as nurse practitioners, physician assistants that practice in our community. They need to be educated in acute stroke treatment and the use of TPA so that they can relay that to their patients, the importance of getting into the ER, dialing 911 should they have them, because they're seeing the patients with all the risk factors. And strategies to provide easy access to telemedicine or air medical transport for rural areas. If we talk with the doctors in the community about possibilities for improving the quality of their patients' care in their local emergency room through telemedicine or air transport, then they'll be willing to participate with us in providing that type of care. Future directions for EMS. I think this is the most exciting time to be part of an EMS service. EMS pre-hospital delivery of potential neuroprotective agents. There's a multitude of studies that are out there looking at various things to try to preserve brain pending thrombolysis or recanalization of the blood vessel, opening up, blocking up, busting up the blood clot so that we can reestablish blood flow. What preserves the tissue during that period of time? Some of these things, if we ever arrive at one that works, and I've been involved in many of them and none of them work so far, but if we ever find one that works, EMS will be able to give that in the ambulance on the way in, and that would be wonderful. If we had a system of care of acute stroke patients waiting for that drug to arrive, we won't have to reinvent the wheel when it does arrive. We'll be ready. It'll be just one additional thing that we do for our patients. Also, the potential for pre-hospital initiation of hypothermia protocols. If we get ourselves ready with being able to do neurologic exams, being able to do some treatments in the field, hypothermia could be started, for the anoxic encephalopathic patient, now post-cardiac arrest. That sort of thing could be started in the field. They're looking at hypothermia in the hyperacute stroke patient or the acute stroke patient as something that maybe potentially, those studies are still out there right now, that might be something for the future. And also EMS involvement in clinical trials. The example I have for that is called the FAST-MAG project, and that's through UCLA in Los Angeles County EMS. And I was shocked at the number. When I trained out there, they had probably about 7 or 8 EMS services that were involved in FAST-MAG. And now 10 years later, they have, I couldn't count them all, but there's well over 100 EMS services throughout Los Angeles County, which is just one humongous. It's like a third of the state is LA County. It certainly is about a third of the population. And all these EMSs participating in this clinical trial of giving magnesium IV as a neuroprotective agent. Now don't get excited, they haven't proven that it works. But the thing is they have coordinated their services to be able to provide this medication. They get the consent done, they got all figured out how they do it, give the drug or the placebo, and get them into the ER, and then they get their thrombolytic therapy once they get to the ER. If this works, then this would be a medication that we would want to provide for our patients right here in Arkansas. So we want to be ready, if FAST-MAG does work, be ready to provide this kind of treatment. So my last thing, and I show this just about everywhere I go, is to emphasize once again that time is brain, and that's what we're talking about here, is getting patients treatment as soon as possible. This was a systemic review of the literature. Neurologists like myself love to count cells. That's kind of what we love to do in our spare time. And so what we did is we counted a whole bunch of cells, so we know how many nerve cells are per cubic whatever of brain tissue. And then we also know that strokes grow as, without TPA. then the strokes will grow with time. So you could start out with a stroke this size, and by 4 days, you got the guy herniating because he's got a stroke this size. So how fast does a stroke grow over time? And then based on the amount of brain tissue that's lost, looking at the Alzheimer's literature, so this is where it's not really scientific, but looking at the Alzheimer's literature, what is lost as far as cognitive motor function, that sort of thing, with time. So that's what they did. So it's more of an emotional study than it is a true science study, but what they found from this is that for a large NCA stroke, so this is a stroke that has left me aphasic and I can't move on one side of my body, that the brain accelerates about 36 years with that stroke. Now the patient has a stroke. For every hour the patient doesn't know they're having a stroke, or the caregiver doesn't know they're having a stroke, and so they're sitting at home having a nap, they are aging 3.6 years. For every minute that EMS doesn't know that they're going out to a hyperacute stroke, instead think they're going to pick a lady up and put her back in a wheelchair, 3.1 weeks. And for every second that we don't know how to do a visual field testing while we're doing the NI stroke scale, our patient is aging 8.7 hours. This is why we have got to be just perfect at this. I mean, I don't know any other way of saying it. EMS has got to get out there timely, dispatch got to know what they're doing, they got to get them in the ER, we got to be prepared, and when it's time to do that stroke scale and you see the grump, me, up there saying, do it this way, do it that way, there's a reason for it, is because I feel the time ticking away. And I'm seeing a patient that's 50 years old that I think might be going to a nursing home, and it's just killing me. And it should be killing you too. So that's why we got to go so fast, because we don't want them to go to the nursing home. We want them to walk on out of here and then go tell everybody else what kind of a miracle drug we have, because we do have a very good drug. The quicker we can give it, the more likely we can have an excellent outcome. So if we haven't figured it out, stroke is a medical emergency. Call 911, and it did it again. I don't know why it did that. Let me see if I can do that. There it goes. So if you notice anybody's having symptoms of stroke, we got to get help immediately. That's got to be our mantra in our community.